Assalamualaikum warahmatullahi wabarakatuh. My name is Syaira Afika binti Subri, and my case report is about acute Stanford type A aortic dissection diagnosed by transthoracic echocardiography. What is aortic dissection? Aortic dissection is a serious and potentially life-threatening condition where there is a tear in the inner layer of aorta. When this tear occurs, blood can flow between the layers of the aorta wall, causing the layers to separate, or we can call dissect. As we can see in the diagram, the tear occurs in the inner layer of aorta and the blood flow between the layers of the wall. This is the classification of aortic dissection. It has Stanford A and B and DeBakey 1, 2 and 3. The most common aortic dissection is Stanford A, which is it occurs at ascending aorta and it can extend to arch or descending aorta. So the treatment is emergency surgical, and for the Stanford B, it occurs at the descending aorta only and it only need the medical treatment. For the DeBakey one, the location occur is at the ascending, then to the arch and descending aorta. The treatment also involves surgery. DeBakey 2 located at ascending aorta only, treatment also surgery, and lastly for DeBakey 3, it start in descending aorta and may extend downward, and it also involves the medical treatment. The risk factor for aortic dissection include age, which is 60 and above, smoking, male gender, poor diet, hypertension, and atherosclerosis. Another risk factor includes the conditions and procedure that affect the aorta, which is bicuspid aortic valve, coarctation of aorta, aortic valve replacement, and coronary artery bypass graft. Other than that, the conditions that affect connective tissues also include in risk factor, such as Marfan syndrome. This is the important echo findings in aortic dissection, especially for the type A. Firstly, we have intimal flap. It is the most specific findings, which it appears as a mobile linear structure separating true and false lumen in aorta. Then aortic root diameter, it can dilate in the type A aortic dissection. The normal value is less than 3.7 if dilated root suggested ascending aortic involvement. Then aortic regurgitation, we can use color Doppler to assess severity. For the severe AR, jet width over LVOT ratio can be more than 65%. Lastly, pericardial effusion or tamponade, which we can see in type A dissection if the blood from the aorta leads into the pericardium. A 59-year-old man presented to the emergency department with a chief complaint of sudden onset of severe tearing anterior chest pain at rest, which radiated to the back, associated with shortness of breath and cold sweating. On admission, he denied a history of smoking, hypertension, and Marfan syndrome. The vital signs include the temperature, which is 35.8 degrees Celsius. Right arm pressure is 105/57 mmHg. The pulse rate is 50 ppm, which is also demonstrated on ECG, which is bradycardia, and the respiratory rate is 20 breaths per minute. The mucous membrane is moist and pink. He also had no history of heart murmur, but a new sound was heard near the aortic valve area, which suggested diastolic murmur. It can be strongly suggest that aortic dissection occurred. As a result of tearing chest pain, TTE was done to the patient. It showed dilated aortic root with dissection flap superior to the sinuses of Valsalva, which associated with severe aortic regurgitation, which strongly suggests the aortic dissection. In image A, It is the Platts view. We can see the aortic root dilation, and it has a dissection flap which is shown by white arrows at the level of sinuses of Valsalva. Then in the image B, it is the Passat's view at the AOPA level, and it also showed a dissection flap which is the white arrows. Then in the image C, for the suprasternal notch view, we can see a dissection flap in the ascending aorta at the level of sinuses of Valsalva, which is shown by the white arrows. And lastly, in the image D, it is the apical 5-chamber view. We put the color Doppler at aortic valve, and it showed severe regurgitation with a jet and a large vena contracta. Subsequent computed tomography, which is CT scan, confirmed the TTE findings and also demonstrated the dissection extended to the bilateral common iliac arteries. CT scan showed that the dissection, which is the red arrows, involved in the ascending aorta and descending aorta in image A, and aortic arch in image B. The dissection also extended to the bilateral carotid arteries and left subclavian artery in image C with thrombi formation, and to the bilateral common iliac arteries in the image D. For the treatment, the patient underwent the emergency replacement of the ascending aorta. However, sudden onset of cardiac arrest occurred 7 hours after the surgery, and the patient passed away 20 hours after admission to the emergency department. In conclusion, aortic dissection is a life-threatening condition that requires early recognition and prompt management. Key signs include sudden chest pain and a new murmur, even though the patient has no history of smoking, hypertension, and Marfan syndrome. Echocardiography is important for diagnosis, with the intimal flap, true versus false lumen, aortic root size, and the presence of complications like aortic regurgitation being critical findings. Timely treatment can save lives. Making awareness and rapid assessment is important.